Hi everyone, today we're talking about Parkinson's disease. Now, this disease was discovered by a scientist named Parkinson. That's the reason this is called Parkinson's disease. It is associated with neural degeneration. So, very important. This is a neuronal degenerative disease. So, basically, this damages the neurons and it is irreversible, progressive as well as irreversible because obviously it's damaging the neurons. And which neurons exactly? The neurons in the substantia nigra, and substantia nigra is known for releasing dopamine. So basically, this is damaging the dopaminergic neurons, right? So basically, I told you in Huntington disease, dopamine was excessively being secreted, whereas in Parkinson's disease, dopamine is less. In Huntington disease, dopamine was more because of which there was choreiform movements. But in Parkinson's, dopamine is less, so the movement will be less. That's the reason the person is going to have tremors. And what sort of tremors? Resting tremors. Because even while the person is resting or sitting, even at that time, he'll be experiencing tremors, pill rolling tremors. So basically, as if the person is rolling pill between their fingers. And yeah, so basically, the dopaminergic neurons are being damaged, and to a lesser extent, the neurons of the globus pallidus, putamen, and caudate nucleus. So here the globus pallidus and putamen, these two collectively are known as lentiform nucleus. And then when you include caudate nucleus as well, these three are known as corpus striatum. So basically corpus striatum and substantia nigra. Now the degeneration of the inhibitory nigrostriate fibers results in a reduction of the release of the neurotransmitter dopamine within the corpus striatum. This leads to hypersensitivity of the dopamine receptors in the postsynaptic neurons in the corpus striatum, which become overactive. The characteristic signs of disease include tremor and cogwheel rigidity, hyperkinetic activity, and difficulty initiating voluntary movement. So, when a person is unable to initiate voluntary movement, that is basically akinesia, which are slow hypokinetic activity. So, hyperkinetic activity is the cogwheel rigidity, and hypokinetic activity is the akinesia because the person is unable to initiate the voluntary movements. I hope that's clear. Now, here you can see that Parkinson disease is a progressive disease of unknown cause that commences between ages 45 to 55 years old. It is associated with neuronal degeneration in substantia nigra and in globus pallidus, putamen, and caudate. Right, and this affects a lot of people worldwide. Now, this is a diagram that you can see potentially. It's showing the CT scan as well. The flowchart was there above. That was for Huntington disease. This flowchart is for the Parkinson's disease. The degeneration of the neurons of the substantia nigra that send their axons to the corpus striatum results in reduction of the release of the neurotransmitter dopamine within the corpus striatum. So basically, substantia nigra, it sends its neuron to the corpus striatum. So when there is reduction or degeneration of these neurons, there'll be fewer axons going to corpus striatum and there'll be fewer release of the dopamine within corpus striatum. This leads to hypersensitivity of the dopamine receptors. They'll become sensitive in postsynaptic neurons in the striatum, right? Because the neurons were going from substantia nigra to the corpus striatum. So now corpus striatum becomes we can say sensitive to the dopamine receptors. Now, patients will have tremors, they'll have rigidity. The tremor is the resting tremor, rigidity is the cogwheel rigidity. Other than that, there is bradykinesia or akinesia, and there'll be postural disturbance. So, for this, there's a mnemonic that you can learn, which is TRAP, TRAP. So, A is basically akinesia. So, this way you'll be able to recall. So, resting tremor, then there is cogwheel rigidity, there is akinesia or bradykinesia, and there'll be postural disturbance. The tremor is a result of alternating contraction of agonist and antagonist. The tremor is slow and occurs most obviously when limbs are at rest. It disappears during the sleep. It should be distinguished from the intention tremor. So intention tremor was different. That was seen in cerebellar disease. Right now we're talking about the resting tremor, right? And also there's essential tremor. That's a different thing as well. Now, this is different as to that which was caused by the lesions of the upper motor neurons, in that it is present to an equal extent in the opposite muscle groups. If the tremor is absent, the rigidity is felt as resistance to passive movement. So, for example, if the doctor or the examiner is trying to, passively move the arm, there'll be plastic rigidity, there'll be resistance, and there'll be series of jerks. This is known as cogwheel rigidity. Then bradykinesia is basically, or akinesia. Akinesia is difficulty or a person is completely unable to start the voluntary movement, and bradykinesia that the voluntary movements will be very slow. And the face is expressionless, and the voice is slurred and unmodulated. Swinging of the arms in the walking is lost. So even when they're walking, their arms are very stiff. Postural disturbance. The patient stands with a stoop and his or her arms are flexed. The patient walks by taking short steps, short shuffling steps, and he may break into a shuffling run to maintain balance. Neither loss of muscle power nor loss of sensibility occurs since the cortical spinal, so there is no loss of sensibility, right? And the superficial palmar reflexes are normal and no Babinski response is seen. The deep tendon reflexes are normal. So basically, trap is the main issue. That there'll be tremors, there'll be akinesia, there'll be postural disturbance, there'll be rigidity. So these are the four things that will happen in Parkinson's. Why? Because there is neurodegeneration of the neurons, which neurons? Dopaminergic neurons of the substantia nigra. Because of which, what happens is that dopamine does what? It helps to maintain the basal ganglia. Basal ganglia causes movement. So basically, it helps to regulate all of basal ganglia helps to regulate all of the neurotransmitters. So when there will be very less dopamine, so the movements won't be regulated. In few types of Parkinson disease, the cause is known, but mostly it's unknown. So post-encephalitic Parkinsonism developed following the viral encephalitis outbreak, in which the damage occurred to the basal nuclei. So this is post-encephalitic. Post-encephalitic was because of the viral encephalitis. Now, laterogenic Parkinsonism can be a side effect of antipsychotic drugs. And yes, and other than that, meperidine analogs used by drug addicts and poisoning from carbon monoxide and manganese can also produce the symptoms of Parkinsonism. Then you have atherosclerotic Parkinsonism, which can occur in elderly hypertensive patients. So, there are three types of Parkinsonisms. So, one is post-encephalitic because of viral encephalitis. Then you have laterogenic. Laterogenic is basically because of antipsychotic drugs, or it usually occurs in drug addicts or in people because of carbon monoxide poisoning, and atherosclerotic in hypertensive old patients, elderly hypertensive patients. Parkinson disease may be treated by elevating the brain dopamine level. So, what's the treatment? You have to increase the dopamine level, obviously, but unfortunately, dopamine it cannot cross the blood-brain barrier, the BBB, right? So, it cannot cross that. Its immediate precursor L-DOPA, this is withdrawn, and this is taken up by the dopaminergic neurons in the basal nuclei and converted to dopamine. Other than that, selegiline, a drug that inhibits monoamine oxidase. So, monoamine oxidase inhibitors are used, which is responsible for destroying dopamine. So, monoamine oxidase. So, these are responsible for inhibiting dopamine or destroying dopamine. So, you need to inhibit these. So, monoamine inhibitors, monoamine oxidase inhibitors, you have to inhibit them. For that, you need selegiline, right? What does this do? Monoamine inhibitors, monoamine oxidase. What does it do? It basically inhibits or destroys the dopamine. Now, you can see that evidence shows that selegiline can slow the process of degeneration of the dopa secreting neurons. So basically, this is not a complete cure because there is no cure for Parkinson's. These basically decrease the progression or slow down the progression of the disease. And transplantation of human embryonic dopamine producing neurons into the caudate nucleus and putamen has been proven successful, or it has been proven to lead to improvement of motor function in Parkinson's disease. Evidence shows that grafts can survive and synaptic contacts are made. Unfortunately, many of the graft neurons do not survive. In many cases, degeneration of the patient's own dopa producing neurons. Autotransplantation of a suprarenal medullary cells can be source of dopa producing cells. Anyways, you don't need to know a lot of the details, just know L-dopa and monoamine oxidase inhibitors is the treatment. Since most of the symptoms of Parkinson's disease are caused by an increased inhibitory output from the basal nuclei to the thalamus and the precentral motor cortex, I'll explain this line to you. Surgical lesions in globus pallidotomy have been shown to be effective in alleviating Parkinsonian signs. At present time, such procedures are restricted to patients who are no longer responding to medical treatment. There's also Parkinson disease, which is drug-induced Parkinsonism. Primary Parkinsonism is the most common type of Parkinsonism found in clinical practice. Drug-induced Parkinsonism is becoming very prevalent as well. Drugs that block striatal dopamine receptors are often given for psychotic behavior. Other drugs may deplete the striatal dopamine. Drug-induced Parkinsonism disappears once an agent is withdrawn. So this is also one type of Parkinsonism. I hope that's clear. So we had atherosclerotic, then we have drug-induced. also known as letrogenic. And then you have the post-encephalitic, which is because of the viral encephalitis. So in short, if anyone asks you what exactly is Parkinson's disease, for that you need to recall this. So these are your dopaminergic neurons. In where exactly? In your you can say striatum, sorry, what do you call it, in your basal ganglia, right? So what basal ganglia exactly? Substantia nigra. In your substantia nigra, yeah, this was the word. So in the substantia nigra, you have dopaminergic neurons. So those are basically getting destroyed. They're getting degenerated. So this is a neurodegenerative disorder. We're not talking about the receptors. We're not talking about the dopamine receptors. We're talking about the dopaminergic neuron that has destroyed. Therefore, there won't be proper secretion of dopamine, which means there'll be no movement. And how does the entire voluntary movement? How does it come about? So basically, if your body wants to wants to tell you to walk. So motor cortex is going to send the signals to striatum. Striatum is what? It is the corpus striatum. What is it? What is it made up of? Corpus striatum is made up of. Let's look here. Lentiform nucleus. Lentiform nucleus has putamen, globus pallidus, and then you have here chordate. So chordate and lentiform nucleus, it makes together the corpus striatum. So signals go to the corpus striatum, and from corpus striatum it goes to the globus pallidus. But globus pallidus interna. Right now, what we were talking about is also a part of striatum because you have lentiform nucleus that has globus pallidus and putamen. But that is right now we're talking about the interna one, not the externa one, right? So globus pallidus interna, and from there information goes to thalamus. Thalamus goes like okay, and then it sends signal back to motor cortex, and that's how the action is brought about. So this is the direct pathway, and there's one indirect pathway where the information goes from striatum to globus pallidus externa, and then subthalamic, and then this is going to inhibit the motor cortex. So this is indirect. So this is going to cause the movement. This is going to tell the body to stop the movement. My body is pretty confused. What shall I do? But then thankfully you have substantia nigra, which release dopamine. And this substantia nigra and basal nuclei in short, they have a very important function of controlling the amount of neurotransmitters. So basically, substantia nigra is going to release dopamine, and dopamine causes movement. How? Because it's going to inhibit this inhibitory or indirect method. That's why there'll be, it means it's going to stop this inhibitory movement, but it's going to promote this direct method, which is going to cause the movement, right? So dopamine is basically doing what? It's causing the movement. So you want dopamine. So in Huntington, there's a lot of dopamine that's released in choreoform. But here, because there's no dopamine, so this won't happen, and this inhibition won't happen either. Neither of this will happen. Instead, these things will keep on occurring, direct and indirect. So body will be in a very confused state whether it has to move or not. So this will be basically the tremors, the resting tremors. So yes, striatum, motor cortex to striatum, and from striatum to globus pallidus, and then to thalamus. This is the direct pathway. I hope you can recall. So this is what I was talking about that you must be getting confused. So increase inhibitory output from the basal nuclei to the thalamus and the precentral motor cortex. So thalamus and precentral motor cortex, surgical regions. So they're saying basically increase inhibitory output. Yes, so that's it.